All right, so we're back on our dog snuggling shirt again. Because I just love that shirt, actually.
That's my favorite shirt.
I'm gonna have to get one.
I'm surprised it's not covered in
I
dog
should
hair, in
probably
all
get a
honesty.
dog.
Yeah, you should get a dog.
Yeah. We got a kid upstairs that wants a dog, so we're trying to hold out, but we'll see.
Just do it.
Yeah.
It'll make everything better.
Anyways, I'm Jason Jolson.
I'm Jay Davis.
I'm a paramedic of 34 years, paramedic clinical educator as well, and I run emseducation.ca.
Yep, I worked on the road as an advanced care paramedic for quite some time. Got a PhD in physiology. Yeah, it's fancy. It's not as fancy actually.
That's why he's here.
Yeah.
Smart guy.
No, not so much. No. I like cells.
Okay, so this is part 2
Yeah.
of our shock series, I guess we can call it.
Yeah, you betcha.
Now we're on part 2 because the one before was just shock. Now it's shock part 2.
No, it's shocking.
Yeah. Didn't you use that one in the last one?
It's Return of the Shock.
Yeah. Return of the Shock.
Return of the Shock. Yeah. Shock part 2. Return of the Shock. That's what it is.
Okay, so this one we're going to talk
We'll
about
call it the shockening.
the shock. That's the next one.
Oh, the third one's
This is the Return of the Shock.
It's the Return of the Shock, and then the shockening.
Yeah.
And then live, shock, die hard, or something like that.
Yeah, it'll be like something like that.
Okay, cool, fantastic.
Anyways, what are we talking about today?
Hypovolemic shock.
Hypovolemic shock. So let's get into it.
Let's do it. All right.
That is not hypovolemic shock, well, the way we want it, but let's get into it here. We'll make it work better.
There we
Maybe no.
go. Oh.
There you go.
Damn, there it is.
There.
Hypovolemic shock and EMS. That's us.
I just want to point out, because I really enjoy these AI images. This is a very good AI image for EMS. I just want to say,
It's not so bad.
like, other than his extra fingers,
And that weird, like, shadowing line on the patient on her arm, her left arm. It's not bad.
it's actually pretty good. But for extra fun, this is a side note. Sign up for one of those Mid-Journey things and start typing and try to get this thing to make you EMS images, because it is horrible at doing it. They're quite frightening, actually.
I mean, but yeah, I am kind of jealous of his biceps.
Oh, they're huge, aren't they? Look at the size of that one compared to his other one.
I think I'm getting well, the more I look at this, the more upset I become. Yeah. Also, is he doing a BP on her leg?
Yep, he's doing a BP on her leg, I think.
Yeah. Okay. Oh wait, it's not the cuff's not even. Okay, you know what? We're just gonna move on.
Yeah.
Okay.
We gotta move on because
Yikes.
So, hypovolemic shock.
Yeah, you betcha. So we're gonna go through a bunch of things here today, guys. This is what we're gonna look at. We'll just go on to the next thing.
We're gonna do the signs and symptoms, treatment.
Yeah, all that kind of fun stuff.
Fluid resuscitation.
Different fluids we can give in the field. Some that we can't give in the field but work.
Yep.
Like we don't touch alcohol.
But the big thing is how to recognize shock.
100%. That's the big thing. It all comes down to recognition.
So when we talk about hypovolemic, a few things.
You betcha. So when we look at hypovolemic shock, basically we're just looking on volume. Right? It's hypovolemic. It's low volume. Okay, guys? That's the big thing. Now there's a couple different types of hypovolemic shock that we can look at. We can look at true hypovolemia, which is someone's volume is moving down for some reason, versus hemorrhagic, which is also a type of hypovolemic shock, but it's because you're bleeding out. Okay. Now, this, just like the distributor shock that we looked at, is going to have a couple different phases. So you're going to have your early and late phase, or your compensated and decompensated phase. So if I'm losing blood volume, or not blood volume, I should say, if I'm just losing volume from my system, then what are you going to notice on me? Like if the stuff in my veins,
you're not going to be as puffy.
Like,
okay, maybe not puffy. Not that kind of puffy. But you're going to look kind of gaunt, right?
Yeah.
Your color's not going to be as good.
You're going to look sunken.
Yeah.
Right?
You're going to have those dry lips.
But what about, let's say, if you put a BP cuff on me, what are you going to notice?
Well, if we start out, right, if you're just losing that volume, you'll have usually a normal to maybe a low blood pressure, maybe.
Okay.
But while I'm doing that, I'll be like, hey, your pulse is going faster than normal.
Exactly.
Right? So the pulse is sometimes, like we talked in the other shock, is one of the key indicators that somebody has got into that compensated.
Awesome.
Right? Because it's kicking the pulse up.
Exactly.
Right?
So you might look normal on one thing, but something else is leading you to believe that something is awry.
And sometimes it might be, before you even get that far, it might be just you don't feel well.
Yeah.
Right? I'm a little nervous. I don't feel well. I'm lethargic.
General malaise.
It's almost a behavioral difference, right? In what is normal for you.
I've had diarrhea for the past 6 days.
You know. And that's
and we're talking about shock as well.
Oh
yeah. But let's say I just came back from my trip to Mexico and I've been vomiting and I feel like junk and I can't stop pooping. Oh my god, it's like I've.
Is this you when you come
Oh,
back from Mexico?
that is me. That
Because
is me.
like you've lost so much volume. You're so much smaller
Right?
and gaunt looking, like sunken.
He has fluids with him though. That's pretty
Yeah,
impressive.
it's probably not keeping it down because if you do get the that revenge, whatever they call it in Mexico's revenge, it doesn't matter how much you drink, it's just going to go through you.
Exactly. Right. So because we can't keep those fluids in us, volume is going to decrease, and when volume decreases, then we get badness in different ways. But as Jay said early on, we might know as EMS shows up on scene, we might not notice
Yeah.
that really crappy blood pressure, which will eventually happen. You can only compensate for so long, but it might look like a normal to slightly low BP, but that heart rate's going to be the big indicator.
Well, again, we're talking about compensating with the heart rate going up. The other thing too is unlike the distributive shock, where it's a container issue, right? The container just went too big.
Yeah.
That so the container is really big. We just don't have enough fluid.
Exactly.
The container will actually squeeze, right? Our body will actually squeeze that container down to try to push that fluid out.
Exactly. So
Right.
our bodies now, exactly. So instead of getting that vasodilation, our body's going to naturally want to do some vasoconstriction to compensate for the fact that we're just losing all kinds of.
So we did talk about coming from Mexico, right? Kind of the nausea and vomiting and the diarrhea thing.
Yeah.
But so some of the other ones that we can look at too, right, are traumatic injuries.
100%. So traumatic injuries are a big one when it comes to hypovolemia, whether it's hemorrhagic or like just loss of volume altogether, right?
Yeah.
So this could be oh well, a simple one. Everything I'm thinking of is hemorrhagic, both internal and external. But
The big thing too is this is where when you get into EMS, this is the one that you get excited about, right? This is the EMR one.
yeah,
You get excited because this is the one that you can see. You go for a guy that's been stabbed or shot in the leg, or he's out in the backyard cutting wood and he's used the axe wrong and he's chopped part of his leg open and he's bleeding out a lot of blood. So
Yeah.
so you have that. When you first start, that's the easiest one to fix, right? Because just plug the hole and put some pressure on it and stop the fluid coming out.
yeah.
Then we have the internal one where you can have some type of internal bleeding.
Yeah, like so you could have like let's say a sudden impact
Yeah.
or a massive deceleration in a car that's going to lead to some type of internal injury.
Or if you're a skateboarder and you want to, like those competitive skateboarders
Oh,
that fall
yeah.
like 50 meters onto their hips.
Yeah, broken pelvis.
Yeah,
So you're
pelvis.
losing.
And you got a lot of fluid. If you think about how much fluid can you lose in your belly or like your pelvic area before you're gonna actually see anything. You'll definitely see the the heart rate, the blood pressure, but you physically aren't going to see it like somebody who's actually cut something.
Yeah, exactly.
Right.
Right. So for those internal ones, the bruising doesn't set in for quite a bit of time, so you're not going to see that.
Yeah.
However, tenderness is going to be
Yeah.
there, right? But both these traumatic ones, we are definitely looking at more of that hemorrhagic or the actual physical loss of blood, whether it's losing it to the outside world or if I'm
Yeah.
losing it to like inside my body. The end result's the same. It's not in my vessels. So I have a friend, and she explains this the best is in EMS. You only got to remember two things: is air goes in and out, and blood goes round and round.
Yeah.
And if blood stops going round and round, like it's leaving my
Yeah.
body, we got to fix that.
So one of the things that we don't talk about, or they do talk about now, but more than usual, is that if you show up on scene, or I mean, you do it in a classroom, right? You go do your scenario, and your instructor or your person giving the scenario is working really hard. Going, you see a lot of blood, and you're like, yeah, okay, I'm going to do my LOCs now, and like, no, you see a lot of blood spraying. So what we're trying to do is we're trying to teach you like we need to stop that blood, right? We need to stop the bleeding right away. Yep. It's the first thing. If the patient's in cardiac arrest, and it looks like they got blood pooling out of them, what do I need to do?
You got to stop the blood.
I got to stop the blood because I need the blood in the body
in order
to take the hemoglobin, all the nutrients. Doesn't matter how many chest compressions I do, if I don't have something to circulate.
Exactly, and what you're pushing on the chest is it's not really going to help.
If you got something up high, you spray yourself.
Right, face, exactly. Right? It's just it'd be gross. And then lastly, we have the dehydration. Like we say, we're kind of came back from that trip to Mexico, or just pooping ourselves silly.
And that's quite common, actually, right? Like you go to houses with children.
Oh God, yeah,
right?
Yeah.
They get a fever, they got a little GI upset, and because their bodies aren't as big, they don't have as much blood volume, so they do compensate really well. But when they decompensate poorly, right? They really they got that cliff and they fall off.
Well, they actually decompensate well because they decompensate like champions.
Yeah,
it's hard and it's fast. Going for gold on that whole decompensating thing.
So history is a big thing, right?
Yeah,
so
definitely.
History is huge. So especially those dehydration ones.
Yeah, definitely. Has something changed in your diets? How long has this been going on for?
And time.
Yeah.
Right. If they've been nausea and vomiting for the last 3 days, diarrhea, they're probably going to be hypovolemic.
Exactly. Right.
So,
And we've all definitely had a little bit of hypovolemia
yep.
in our lives. However, we've never got to that super, well, probably most of us never got to that super extensive like hypovolemic shock state, because we do have a lot of body systems that come into play to tell us, like, hey, idiot, you're thirsty, drink water.
You know what's really funny
Or you're
about this
salty things.
is this is self-induced sometimes, right? We got people that play sports. Like if you look at these distant runners, like if you look at
Yeah.
a thing called Death Race or Sinister Seven, where they're doing these long marathons, and these guys are going up and down mountains, and they're not hydrating enough, or eventually they get to the point where they actually make themselves sick. Where if they do hydrate, it ends up either peeing out really
Yeah, there's
fast,
vomiting.
or they end up with diarrhea, right?
Yeah.
So again, dehydration isn't just because you've been sick, that kind of thing. It could be, or if you're working out in the heat,
Yep.
right?
Yep, you betcha. And one of the things that you're gonna kind of, what people will tell you if they
Yeah.
do get to this dehydrated state is that like they're craving salty things,
Yeah.
because that's one of your body's ways of like, like, well, because what happens is salt is an ion, and ions will absorb better. Which is not the whole point of this. But
No.
that's something that if you have a patient being like, listen, man, I'm craving something salty.
I know we've already talked about this,
Yeah,
but
we can go through it quickly, I
can
guess.
you go through it again?
Yeah, you betcha. So that heart rate's going to be fast, because we're trying to compensate for loss of volume there. Cool, clammy skin. This is not specific. Cool, pale, and diaphoretic is kind of like a catch-all for almost everything. But we do get this because simply my ability for my body to actually perfuse is decreasing, and if my perfusion's going down, I'm going to feel cool. Weakness and fatigue, general malaise. If someone stands up quickly, they may be dizzy. So these patients,
They do faint.
yeah, exactly. They're going to be ones that if you ask them to like, hey, I'm going to get you to stand up so you can get on my stretcher for me, make sure you're there with them, helping them with the transfer valve.
And they might have to ask them a few times, right, to get the questions out of them correctly, because this is right as we were progressing here, they're not getting, like, everything isn't going to the noggin as well. They don't have enough oxygen, they don't have enough glucose going in there. Weakness and fatigue, like when we talk about these runners and distance people, weakness and fatigue kicks in to try to save them from keeping going too, right?
Yeah.
So,
and then you get like the David Goggins of the world, who can, for some, like, I'm not that amazing. Like the second my body says, "Hey Jay, you're tired," I'm like, I'm gonna take a nap. Yeah, I'm not the kind of person that keeps.
Yeah. Oh yeah, I'm the same way.
Yeah, give me a sandwich.
So
this is pretty cool, guys. So this is I wish we had like one of those green screens right now when I could point to this. So this is for different classes of volume loss here. Okay. Now, this isn't something that in the pre-hospital setting we specifically super ultra care about per se, but it's good to know. So we have class 1 through class 4. And this is showing you blood loss here.
Second point there.
Yeah, look at that. Fantastic. Yeah. So we're looking at less than 750 or equal to 750 milliliters of blood, all the way up to greater than 2,000, which is 2 liters. So let's look at class 1 here. So I've lost 750 cc's. Now my heart rate is going to be, normal or just slightly increased. Ventilation's normal, BP normal, and I'm producing this like a normal amount of urine. Okay, so this is, I don't want to say good. You're still losing 750 cc's of blood. That kind of sucks.
But you can tolerate it.
100%, right? Because when you donate blood, you're donating about 500. So this is just slightly more than that. So this is something you can probably deal with. But if we look at class 2, we're going to about double that. So we can get up to 1.5 liters here. Heart rate is going to not quite be super tacky, but it's greater than 100. Ventilations are increasing. But look at this. My systolic is still normal.
And that's that compensated shock we keep talking about.
Exactly. My body's able to compensate for this. So I get this vasoconstriction, but my pressure looks normal here. Urine, okay, so 20 to 30 mils an hour. Who cares? As EMS, we're typically not measuring urine.
Yeah, at that point, we're not worried about that.
Right?
Right.
Now, class 3. So look at this. From class 1 to class 2, we went from 750 to 15. But for class 3, we've gone from 1,500 to 2,000. So it's a much narrower margin.
Yeah.
But look at what happens. Tachycardia.
The jump's way bigger here.
100%. Tachypnea. Right? BP decreased. I'm no longer compensating. Okay,
and this is the big one right here.
Yeah.
Right? The blood pressure. Like when we start talking about this the compensated shock. This is what we're looking at.
100%.
And when we talk about compensated is we're maintaining perfusion. When we have that decrease in blood pressure, we have hypoperfusion starting. Right?
Exactly. So,
or it's, well, and as you get to the next one, we'll see it's greatly impacted.
oh yeah. So if you lose more than 2 liters, so this is about 40 or greater than 40% of your blood volume, you're running at about 140 beats a minute, greater than 35 breaths a minute. Like your blood pressure's just junk. When we see this in EMS, we're pooping ourselves.
Yeah, this guy is going to be sick. And the other one too is if you look at this rate, you can get rates upwards of 160 that are still not an SVT, or you see people get into that, oh, it's an SVT or it's an atrial attack, but then it really actually is just they're depleted their volume so bad that they're doing the heart is basically maintaining the trying to do everything it can to maintain that pressure.
Exactly.
And what happens if you go for a run at 140 for a long period of time? You get tired. And that's what's happening here.
If I go for a run, right. It's 100 for a long period of time.
Right. So you get this fatigue that everything starts to fail. Right. And that's why we talk about that, like compensated. If I can get in there right away and recognize it before he's even getting really compensated, like if we talk about
that's awesome for us.
Yeah. If we go here, this one here, right, there's not much going on. So we can fix that easily.
Yeah.
Or
exactly.
stop it or keep it from getting worse.
Put a cork in it. Done.
Where we get to this one, we got to start paying attention. We got to start working. But when we're over here, this is the worst one here.
100%. So in class 1 and class 2 as EMS providers, we're not like, I mean, we're doing our job. We're feeling okay. Like it's not too scary yet. You know, I don't see anything so far out of the norm where I don't think I can't handle this. However, when we get to that class 3 and class 4, I'm scared.
Well, you got so much you got to deal with, right?
Yeah, this is a stressful situation.
So a class 1, if you're looking at class 1, even a class 2 person, if they're not dehydrated, let's say they're bleeding out, it's easy. Stop the bleeding.
100%. You know, I can do this with 2 people. I got someone driving, got me in the back dealing with that. That's doable.
And that's a BLS skill.
That is a BLS skill. Class 3 and class 4. These are scary. Not fun. Not fun. So let's talk about this. How do we treat it? First things first there.
Hey, look, see how we treat it.
Bam.
Pass it.
I like it. Is we got to plug that hole, right? So first things first is control that bleed. I know this says number 2 here, but like if someone's bleeding, you know, it's on like when you guys are going through school, it's LOCs, ABCs. As I approach my patient, do I see any deadly bleeds or angulated fractures? If there's a deadly bleed, as Jay said earlier, we got to deal with that.
Yeah, and the thing is, you walk into that house and you look over and go, that's probably better do something. Right? You know they're that sick. They made you stop a second and go, holy crap, we're in trouble. And if they're bleeding, if you see a lot of blood and it's like blood-soaked pants, something's soaked in blood, you need to open it up and you need to visualize it.
You gotta put eyes on it.
Right, and you need to stop. And one of the simplest ways too is just that your hand, right? You got your gloves on. Even a glove hand can be this first line, right?
Heck yeah, definitely.
Before you get into the other fancy stuff to do it.
Now, other than that, we can, depending on your scope of practice, is we can give fluids. Now, we can give fluids intravenously or we can give fluids orally. If I have a patient who's able to ingest some stuff, then it's going to take longer. It has to go through the gastrointestinal tract, but it's going to increase.
But if you look at the class 1, if they haven't lost a lot of fluid,
they're fine.
Or they've been taking some fluid, they can drink it and they'll get it back. Right?
Exactly. So like you said, like if you're donating blood, you're losing 500 cc's. They're not going to be like, hold on, we have to give you an IV. No, you're just going to drink and water and eat some chips and you're fine. Okay. Now, the fluids we can give, I'll talk about coming up, but the last thing is oxygen. So if I am losing blood volume, one of the general thoughts is kind of like, if I have lost volume, I want to make sure that the blood that I have is fully oxygenated to allow for perfusion. There's a couple issues with that, because depending on why someone's losing blood or something other, that's like secondary comorbidities, sometimes oxygen is actually a bad thing, right? But we can talk about those caveats later. So,
the big thing about the oxygen is that when we're bleeding out, we're losing hemoglobin. Right. So the more hemoglobin on your floor, if you think of it, is I'm waiting for my Amazon package today. Right. And all of a sudden, all the Amazon drivers don't show up. There's less packages going out. So less of that oxygen is going out, being delivered to the cells. I don't get my package right away. So sometimes don't be afraid. Like if they're kind of on that borderline, right? They always talk about 94%. right? If we flood somebody with oxygen, we can cause some vasoconstrictions. But the biggest thing is that if you think this person needs oxygen,
Give them oxygen.
give them oxygen.
Yeah. Yeah, definitely. Definitely. If you think they need it, do it. Okay. Now,
Well,
when we look at that as well, is oxygen is super beneficial, but as Jay said, it can cause things like vasoconstriction. Okay. So we'll worry about that later. You know, these are things that, like, depending on difference, like if I have a patient who is a stroke patient, then I might think about this differently. If I have someone who's
yeah.
having cardiac arrest, I might think of this differently. But when it comes to hypovolemia, you're probably going to be pretty safe.
Yeah, and you're right. In trauma is 20 mils per kilo.
Yeah.
So it's a large volume that
Yeah.
you can deal with. It's not like a cardiac patient where you're worried about the volume of that.
Exactly. All right. So what
some of those options?
fluids? Okay, guys. So we have our crystalloids here. So you have your lactate ringers, your saline, some pretty simple stuff. Now we use crystalloids a lot. In
Yeah,
EMS.
primary.
Like this is our go-to. Our colloids, things like albumins and stuff like that, our dextrins, we don't use as often. They can be used.
Yeah, they're usually used in a special environment. Usually, it's a special offshoot of your traditional EMS, right? You might have a team. You might have a TEMS team that might have stuff on standby. You might have like our critical care paramedics might be using that, or not a critical care, community care.
Community
Right?
care paramedics. Yes.
Their scope's a little different, right?
Exactly. But crystalloids are definitely our most common. And then lastly, you're not going to see this too often in EMS unless we're transporting a patient with them, but we're not really ever ordering blood products. You know.
No.
However, occasionally we will have a patient who needs blood products who we're going to transport, then we're going to, depending on our scope, monitor and do things like that. But for the most part, we like saline, we like ringers, we like D5W.
And the thing about those are, though, we can give a bunch of fluid, but it's not restoring the hemoglobin.
Exactly.
To put the oxygen on.
We're just putting fluid in the
system.
So
the blood gives you a capability of carrying oxygen, right?
Yep.
So we just added more trucks to that. You are prime, get that package to me so they can get more oxygen to this cells and that.
Yeah. So not too much there. We're not going to spend too much time talking about these because your guys' protocols will dictate what you can and can't do and different like amounts and stuff like that. So what we're going to talk about now is just how do we recognize this? But like we've kind of already alluded to this a bit. But get a history, guys. That's the big thing is figure out what's going on with your patient. So we are like fantastic at interviewing patients. That is one of our key jobs.
So the best is dehydration, right? Have you been nausea, vomiting? How much you've been vomiting?
Yeah.
How much diarrhea you've had? And how loose is your stool, right? Like how much is it pouring out, or you have any inconsistency to it? And the problem is you have to get into that, right? Like,
oh God, you got to talk about.
You get into this job and you'd be amazed what you're going to ask somebody.
Oh, totally. Like if you can't talk about poop with a stranger, then who can you talk about?
Exactly, right? Yeah. So the history doesn't match the story.
Exactly.
Right. That's the biggest thing. When you got a traumatic event where you got blood, it's usually more obvious.
Yeah.
Right.
Yeah.
Right. Plug the hole, or you might have some type of trauma, or there might be something going on that when you're doing the story, it makes more sense.
100%. So like, let's say you have, I mean, a super easy one is, let's say you came to a victim of a type of assault. Let's say they were stabbed. Yeah. Well, that one's pretty easy peasy. If someone was stabbed, knife was taken out, which people like to do because that's their favorite stabbing knife. They're going to take that with them, right? So
if we show up and somebody's got the knife still sticking in them.
Oh, yeah. I mean, leave the hush puppy there. That could be a clue.
Right. It's going to slow the bleeding down.
Exactly. But let's say Stabby McStabberson wanted to take Mr. Stabby back home with them for their next victim, and we see someone who's just gushing. Super simple.
Yep.
However, let's say I have a sudden deceleration. Someone's been in a car accident, and I palpate their abdomen, and it's really distended and really rigid. Well, now we have to put the story together. Okay, someone was in an accident, depending on maybe, let's say, what the steering wheel looks like. You know, if there's seatbelt marks, if there's anyone else around kind of telling us what was going on, I might be like, okay, I definitely have some internal bleeding now because I got this distension.
Well, you do your vital signs, right? Do a set of vitals, and now your pressure on that patient's low.
Exactly.
And you're like, well, they doesn't look that bad, but they do got that firm belly, right? They have the mechanism of injury, so that person probably, because the pressure is low, is probably decompensating, right?
Yeah, exactly, right? Because that pressure is starting to go down. We're in that initial decompensated stage there, and we always monitoring. Oh, geez, most of these patients are going to be Q5 for vitals.
especially if you're dealing with a patient that is bleeding internally.
Yeah.
Right? Externally, we got control of it. If you had to use a turnkey wound packing, doesn't matter what, you need to go back and make sure that it's still controlled,
You
right?
betcha. Yeah, tourniquets, guys, they
Reassessment.
reassess. They can slip. They can loosen up over time. Yeah,
Yeah.
monitor, reassess, and treatment. I mean, we do what is in our scope. And your different jurisdictions do what you're allowed to do. So if you are allowed to push fluids, and this is the patient you need to push fluids
Yeah.
for, you're going to push fluids. If you watched a YouTube video on how to place an IV, and you took a water bottle and started shooting
Yeah.
some Evian in someone,
Yeah.
you're probably going to be liable for
Yeah.
hurting someone. But if it's in your scope of practice, you've been trained how to do it, then that's
Yeah.
what you're going to follow. But Jay and I have given, oh God, truckloads of
Copious.
fluids.
And I've given so much fluid. Like we had a hypovolemia, right? The guy got stabbed in the femoral,
Oof.
right? So we tourniqueted him up. Actually,
Yeah.
it was low femoral too, right? Like more towards the knee.
Okay.
So we tourniqueted him, we packed him, but I gave him like 4 liters of fluid by the time we got to the hospital.
Yeah.
And as I'm giving it to him, like, this is too much.
Yeah, right.
Right.
But you're trying to keep that pressure stable, and then when it gets to the hospital, they'll probably order blood products at that point in time, and you go.
Well, we phoned ahead, let them know we're coming because we're screwed, right? It's that patient like we're gonna need some help. He needs more than me. When we showed up, they actually had just the O positive or whatever the general that they give, and they just started putting it in them, right?
Yeah,
without
no questions asked.
Yeah.
Just start getting the blood products in there.
I mean, it was unconscious, right? We're dealing with a pressure of about 60, so it's bad.
Like, yeah, that is not a fun one.
So, let's see what the next part is.
Oh yeah, how does this suck? The impact on the body. I mean, it's widespread.
Yeah.
So if hemorrhagic's easy peasy. Okay. If I'm bleeding out, that one makes sense. Everything's gonna initially, well, not everything, but we're gonna initially compensate as much as our body can, but then eventually we're just gonna, need help. But when we look at just relative hypovolemia, if I am losing volume, let's say because of dehydration, just due to vomiting and diarrhea, that's going to put strain on my heart.
Yep.
That's going to decrease my cognitive abilities, right? That's going to decrease my ability to perfuse tissues. So it's going to interact with my nervous system, my cardiovascular system, my respiratory system. It's going to put extra impact on my kidneys because my renal system is now going to not have the proper solute-solvent concentration that it needs to function properly. Something as simple as just diarrhea.
Yep. Of a few days, right? Actually, you can get pretty dehydrated in an evening.
100%,
right?
You can.
If your body kicks in and you decide that it's clearing everything out.
Yeah. If you've had a couple chili cheese burritos with Taco Bell, I'm sorry, Taco Bell, it's delicious, but truth is truth. But that stresses so many body systems.
So and it increases your heart rate.
100%.
It just the natural increase your heart rate is going to put stress on your heart.
Yep, definitely.
Right?
And as that stress goes on my heart, that stresses everything else.
And you've lost fluid, so you have less fluid in your body. So you're actually in dehydration. Your blood becomes thicker.
Yep.
Again, it has the problem of actually transporting oxygen again.
Yep.
But
exactly.
different than whether we bleed now. Bleeding out is obvious because you're just bleeding out.
Yeah, that's the easy
hemoglobin everywhere. That's obvious, but it's going to affect everything, right? And so between that, it's going to work towards your respiratory system. You're going to increase your breathing, but now you can't get as much oxygen or CO2, right? You can't get it in, you can't get it out.
Yep.
Like you talked about, air's got to go in and out, blood's got to go round and round.
Yeah, exactly. So if you can't do that, all from something simple, right? So this is an emergency, right? When you get that call from someone who just feels like junk and they've been in their bed for the last 3 days, and you walk in and it smells like
well, there's an odor,
right? And once you that's a load and go. Let's get this person to the hospital. So we've kind of talked about that to death, but no pun intended. Oh, yikes.
Yeah. So then again, when all that comes said and done, your renal system has a problem because it doesn't have enough fluid to go through. You can't be filtering out. Getting rid of waste, right?
And the crazy thing with this is think of all the hormones that are associated with the renal system, not just the natriureous ones, atrial natriuretic peptide, antidiuretic hormone, the angiotensin 2 pathway, But like when we look at what the renal system is capable of, this is capable of, we look at bicarb,
Yep.
right? And keeping pH. Now my pH is out of whack,
Yep.
right? So once again, guys, it's something so small, some diarrhea, some vomiting, and this has such a broad reaching aspect of your body. This can lead to things like acidosis. This can lead to things like what we've already talked about, most of them, but like it's hormone malfunction deficiency. Like it's through the roof. Yeah, I'll leave it at that.
So I
But like
think
it's
really like what it comes down to is the recognition.
100%. Yeah.
And again, if you can recognize it when it's at the beginning, it's easier to fix than it
100%.
is at the end.
100%.
So when you walk in there and you get that person, it's like, oh, I've had nausea and vomiting for a few days and I don't feel well. And you're like, you look good, your vital signs are good. But that's the point where the intervention is needed.
Exactly.
Right? And
Yeah.
the intervention is easier to fix at that point versus now you're leaving 3 more days, especially if they're like a senior or like you said, a toddler, like we're dealing with children, their blood volume is less. You're dealing with
yeah.
senior, right? They got the complex medical conditions.
Yeah.
Sometimes they're frail. Again, they don't do well, so they're going to decompensate faster. So if you get ahead of that with them, like a UTI, right? You get them in there and get them treated earlier, the better off you are.
I remember I had this one patient, this was years ago, and they were fantastic when it came to like a med regime. They had just got back from a cruise, and so initially you think, oh, it's norovirus, whatever,
Yeah.
self-limiting. But this is like they were like 4 or 5 days at this point in time. So okay, it's not noro. But this individual was so good at following their med regime that they were taking their Lasix every single day, and they were also not ingesting fluids other than like the little bit of water.
Yeah.
So their Lasix were up, and they were like just shitting themselves. Like it was, I mean, it was horrible because they were dehydrating themselves from their meds on top of the dehydration from whatever else was going on there. So, yeah.
So how to prevent it? Some prevention.
Yeah, I mean,
How do we stop it? How would we slow it down as EMS practitioners?
well, I mean, for practitioners, we keep our patients hydrated.
Yep.
Right. That's the big one. Right. So this is large bore, get some fluids in there. Right. That's the big one. We talk about crystalloids, colloids.
So if you're a runner doing these silly runs, right?
Yeah.
So stay hydrated. Make sure you have the right, especially long distance, right? They're going to use more salts. They'll have different electrolyte mixtures of drinks to drink, like Gatorade. Some of these longer ones, they have more fancier ones that kind of get absorbed quicker.
Yeah, like the fire salts or the fire water, whatever they are, with like all the different ions in them.
Safety precautions. We get into if you're working on a construction site, just be aware of your tools. Be aware of the stuff that can actually cause you to lose blood loss or an arm.
Yeah, 100%. Right, definitely. And also another safety precaution could simply be like, hey, if it's super, super, super sunny outside, you can rock it in the shade for a while.
Yep, I remember one time I made my kid walk the rest of the way home because he wanted to ride and got home and I said, well, what'd you do today? Oh, I was outside most of the day. I was doing track and field. And then he said, it's really funny. About an hour ago, I kind of quit sweating.
Yeah, okay.
So when he got home, he was not feeling very well. Again, what we do, we just gave him some fluids.
Yeah, exactly.
And his dad's a paramedic, obviously made him walk the rest of the way. He didn't bother to go get him. And then again, medical alerts, right? If you're on Lasix,
exactly.
Let us know.
Yeah, exactly. Like just keep making sure, like cell phones now, guys. Like, I mean,
everybody has the ability. Oh,
there's the medical alert thing in there, right? So fill it out. If your patients don't have it filled out, like after you send, be like, hey, for future notes, did you know that you have this like emergency medical thing on your phone that has all this information? And it's really good for us to know these things as EMS because it's a good tool for us.
Yeah, and the biggest thing too is it helps us understand what's going on, right? And again, like we talked about the Lasix. So some of the key things we talked about.
Yeah, big takeaways here, guys. And no matter what EMS, our whole thing is prompt recognition. So like,
even if you don't do anything,
understand what's there.
You know what's sick.
Yeah,
get them into the truck and take them to a hospital.
100%. And if you have things that you can do,
and start doing the things you can do.
Exactly.
Right. The second one, like quick intervention. If you're bleeding out all over the place, stop the bleeding.
Easy peasy, right? Yeah. Like it's super simple. First thing you do is gloved hand, then apply like a tourniquet or some type of wound packing or hemostatic agents, whatever's in your scope, whatever you can do depending where it is. But notice it, fix it, transport.
Yep, exactly. So, anyways, what I want to do is in the last one, we showed you a couple things with those containers. Remember the destructive?
Yes.
Or destructive.
Destructive
Yeah,
shock.
destructive shock.
Sounds like a
distributive shock, right?
Destructor.
So if we think about it, when we're getting to hypovolemia, right, we want perfusion. We want all our blocks to line up.
Yeah.
So what's happening is, in that distributive shock, we lost control of the container, correct?
Yeah, in distributive shock, you betcha. So
Yeah.
we had that massive vasodilation, and
So there's my container. I got lots of blood in it. It's being able to push it up into my head. We're doing really well.
yeah, life is good.
Life is good. So then all of a sudden, I lose a whole bunch of blood.
Okay, so I'm bleeding out here.
So you're bleeding out. Can you see now what happens is
So
we don't have enough blood. So
exactly.
one way to maintain perfusion will happen is we're going to increase our heart rate
Yeah, you betcha.
to actually do that. Our body will come along, and what it will do is it will actually now constrict the vessels in the body to make that container smaller to push the blood up. So we got, where's my blue pen? We have an increase, right, to maintain BP. We're going to increase that to make sure that we're getting enough oxygen and sugar to everything,
Yeah.
to nutrients to get stuff out, the CO2 and the bad stuff.
Yep.
We're going to increase the respiratory rate a little bit probably. And then again, because we're doing all that, that keeps our mentation good and everything. So as this starts to decrease, where we have problems where, let's say, we are now lost too much blood.
Yep.
Our blood pressure now is dropping, right? So if our BP drops to that point of that critical, we might see a way bigger increase in oxygen, respiratory rate, way bigger.
Yep,
Like
definitely.
tachycardic, 160 beats per minute.
Definitely.
But again, remember we talked about that. So what if I lost more blood? And that's what would happen there is, right? Even though I squeeze the tank, I still don't have enough blood
Yeah.
where we need to be.
Yeah.
Right. So the biggest thing is remember that, and what happens, and as you can see, this stuff is all connected. Right. So it
totally.
doesn't matter what you do, like we talked about, like the kidneys, that kind of thing. We will be into the situation where you don't have enough stuff going through your kidneys, you end up with a pH balance problem, you're not getting out the medications you're supposed to get rid of your body.
Yep.
And it becomes a systemic thing. So like we said, you start over in this area, right? It's really easy to work on them. This is like your compensated shock. As we get down here, right, you have that decompensated. But on this end, the treatment on this side is way harder than this side.
Oh, definitely. Yeah, 100%. So when you have that decompensated shock, it's just a battle the entire time.
Yeah. So this is our shock.
That was it.
That's about it.
That was hypovolemia.
Hypovolemia, and we'll be catching you on the next one. We got a couple more coming.
Yeah.
And stay tuned.